Bismillah ar-Rahman ar-Rahim. Our lecture today is thyroid gland. Professor Nagi Dessouky, Assistant Professor Muhammad Gharib Khairal. The presenter is Assistant Professor Muhammad Gharib Khairal. Thyroid gland is one of the most important endocrine glands in the human body. Embryologically, it starts to appear by the third week of the embryonic life. It starts as proliferation at the base of developing pharynx, point determined by depression at the base of the tongue called foramen cecum. As it descends, it joins the ultimate bronchial bodies. C cells migrate from the neural crest and join the developing gland. The normal thyroid gland is brownish and red, highly vascular gland. Consists of two lobes connected by an isthmus. Each lobe extends to oblique line of the gland upward and downward to the fourth or fifth tracheal ring. The isthmus overlies the second and third tracheal rings, and normally it weighs from 20 to 25 grams. The arterial supply: superior thyroid artery branch from external carotid artery, inferior thyroid artery branch of thyroesophageal trunk, thyroidema artery from the aortic arch, and some esophageal branches contribute to the blood supply of the thyroid gland. Venous drainage through superior thyroid vein, middle thyroid vein, and inferior thyroid vein, while its lymphatic drainage through extensive intrathyroid network of lymphatics, pretracheal and prelaryngeal to deep cervical and mediastinal lymph nodes. Thyroid hormone synthesis starts by trapping of inorganic iodide. It occurs under the effect of ATP process. Oxidation of iodide into iodine by hydrogen peroxidase. Binding of iodine to tyrosine by tyrosinase enzyme to form mono and diiodotyrosine. Coupling of mono and diiodotyrosine to form T3 and T4, then release upon the need under the control of TSH. Release of thyroid hormone is under the control of thyroid stimulating hormone. Levels of thyroid stimulating hormone is reversibly related to the thyroid hormones. Measurement of TSH normal range is from 0.5 to 5 international per liter. Thyroid hormone levels T3 and T4, free T3 and free T4, thyroid antibodies, and radioactive iodine uptake. They could assess the functions of the thyroid gland. Anomalies of thyroid gland. Thyroglossal cyst. Pathology: it is midline tubulodermoid cyst arising in thyroglossal duct remnant. It assumes variable relationship to the thyroid bone, behind, in front, or to it. Cyst occurs at any level from the foramen cecum of the tongue to the suprasternal notch. Clinically, it represents a midline swelling, moves up and down with swallowing and with protrusion of the tongue. There may be palpable track from the thyroid bone towards the tongue. Treatment is by surgical excision of this thyroglossal cyst with the part of the thyroid bone, and the operation is called cyst trunk operation. Thyroglossal fistula: it is usually acquired due to either infection of thyroglossal cyst and rupture or incomplete removal of the cyst. Pathology: tract is lined by columnar epithelium with charge of thin mucus. Clinical picture: fistula opening in the midline to the left side with crescent fold. Treatment is by excision of the tract with center part of the thyroid bone. Lingual thyroid: failure of the sinusoid gland, it will be occupied the back of the tongue. Clinical picture: swelling of the tongue with obstructive manifestations, either dysphagia or difficulty breathing. Investigation: thyroid scan. Treatment is by replacement therapy with L-thyroxine, surgical excision, or radioactive ablation. Goiter: it is generalized enlargement of thyroid gland. It may be inflammatory goiter due to acute bacterial thyroiditis, subacute thyroiditis, Decoven's disease, chronic specific inflammation as tuberculosis or syphilis, autoimmune as Hashimoto or thyroiditis. Toxic or neoplastic manifestation: simple physiological goiter, simple colloid goiter, or simple nodular goiter. Subacute thyroiditis: Its etiology is controversial but most probably due to viral infection. Clinical picture abrupt onset following upper respiratory tract infection with thyroid enlarged, firm, irregular, slight tenderness. There is pain in the neck, fever, and nausea. It is characterized by remission and excretions, but it is self-limited. Elevated ESR, depressed or normal leukocytic count, iodine uptake decrease with slight elevation of T4. Subacute thyroiditis. Etiology is controversial, most probably due to viral infection. Clinical picture is abrupt onset following upper respiratory tract infection. Thyroid gland is firm, irregular, enlarged, slight tenderness, neck pain, fever, and malaise. It is characterized by emission and expiration, but it is self-limited. Investigation revealed ESR, depressed or normal leukocytic count, iodine uptake, depressed, slight elevation of T4. Treatment consists of the rapid response to oral prednisone is diagnostic and therapeutic. It is used for a few weeks. Autoimmune thyroiditis, Hashimoto thyroiditis, most common form mainly females at menopause. Etiology: antibodies to thyroid antigen with pathology, infiltration of the thyroid gland with lymphocytes and plasma cells. There is replacement of acinar thyroid gland with these inflammatory cells. Clinically, it is of insidious onset, asymptomatic, may be painful. The gland may be lobulated, diffuse, or localized. Soft or firm or rubber in consistency. Early hyperthyroidism manifestation, later hypothyroidism. Investigations: antimicrosomal antibodies and antithyroglobulin antibodies are elevated. In suspected cases, two cut or fine needle biopsy may be required. Treatment: full replacement therapy with thyroxine. Surgical treatment is only indicated when it is large localized lesion or suspected malignant transformation. Rhinothyroiditis is a rare condition accounts for 0.5% of cases. Hard woody transformation of the gland due to extensive fibrosis. It may be autoimmune or collagen disease. Clinically hypothyroid manifestation. Biopsy should be required to differentiate it from anaplastic carcinoma. Simple goiter etiology: iodine deficiency may be absolute or relative. Enzymatic deficiency like Bendit syndrome due to deficiency of peroxidase enzyme. Goitogenous intake: they include cyanocyanates or para-aminosalicylic acids. How does simple goiter develop? At first, there is deficient synthesis of thyroid hormones by iodine deficiency, goitogenous agents, or enzymatic deficiency. It stimulates the hypothalamus to produce thyroid-releasing factor, which in turn stimulates the anterior pituitary to produce excess thyroid-stimulating hormone. Elevated levels of TSH acting on the thyroid gland will produce hyperplasia, increase the number of hypertrophy, increase the size of the gland acini. When iodine requirements are satisfied, follicles undergo involution. Repeated fluctuations in the level of TSH due to repeated cycles of stress produce heterogeneity of the gland with, with areas of active follicles and inactive follicles. Actually, at the end of the disease, at the end of the pathological process, hemorrhage occurs in the areas of and central necrosis of the nodule formation, which are mostly inactive, while active follicles are present in the internodular tissue. Factors other than TSH were implicated in development of simple goiter as immune thyroglobulin, desensitized follicle leading to heterogeneity of the gland. Type of simple nodular goiter: simple physiological goiter, diffuse, soft, and enlargement of the gland. It appears in childhood endemic areas, sporadic cases with increased demand, pregnancy, and puberty, reversible upon stop of stimulus. Simple colloid goiter. Due to hyperinflation of the surgical goiter, patients receive large doses of iodine, so follicles will be distended with colloid. Gland is enlarged with a smooth surface, soft consistency. Cut surface of the gland is glistening, and the follicles are full of colloid. Simple nodular goiter. Multiple nodules are grossly present. Usually one nodule is more prominent. Its complications are tracheal compression or obstruction. It is caused by compression either from side to side or from posterior to anterior. Trachea may be displaced from the midline by a hugely enlarged loop of the thyroid gland to either side. In long-standing cases, tracheomalacia develop with postoperative tracheal collapse. The other complications are secondary toxic goiter formation, malignant transformation into follicular carcinoma 3% of the cases under the effect of TSH, cyst formation, hemorrhage into nodule, calcification, and retrosternal goiter extension. Clinical picture of simple nodular goiter starts early in endemic areas, later in non-endemic areas. Cosmetic deformity or some symptoms of respiratory obstruction. Thyroid is firm with nodular surface. Nodule itself is smooth, firm, and painless. If not complicated, no signs of toxicity. Sudden enlargement or onset of pain indicates hemorrhage. Calcification may result in hard swelling simulating malignant lesion. Investigation included differentiation between simple and mild toxic nodular goiter by thyroid functions, titers of thyroid antibodies to exclude Hashimoto disease, ultrasound examination. Some cases may require radioactive iodine uptake examination. Prevention and, prevention and treatment of simple goiter. Prevention, use of iodized salt tablets in endemic areas. Treatment, diffuse hyperplastic goiter, L-cytoxin 0.5 to 0.1 mg per day. Treatment of seminular goiter surgical if complications started to develop or for cosmetic purposes. Retrosternal goiter. It arises as an extension of the lower wall of the cervical goiter in normally placed thyroid gland. While very few cases are apparent thyroid tissue, the factors which predispose to retrosternal extension from cervical goiter: 1. Attachment of pretracheal fascia directs the extension downward. Negative intrathoracic pressure. Effect of gravity. And finally, it is also commoner in males who have strong pretracheal muscles, compress the swelling, and in patients with short neck. Types of retrosternal goiter. Plunging goiter, it is situated in superior mediastinum and it is retrosternal extension from cervical goiter. It ascends to the neck with deglutition and descends again into the mediastinum through the trachea through the thoracic end. Mediastinal goiter, it is situated in the superior mediastinum or posterior mediastinum. May be retrosternal extension from cervical goiter or an ectopic thyroid tissue. It is connected with the thyroid by a relatively narrow band of tissue and it drives its blood supply from the thyroid vessel itself. It doesn't ascend to the neck with deglutition. Intrathoracic goiter, it is situated wholly in the chest, completely separated from the thyroid gland, and it is nearly always an aberrant thyroid tissue, depriving independent blood supply from intestinal vessels. Clinical picture, symptoms of mediastinal syndrome: dyspnea, dysphagia, edema and cyanosis of the face, toxic and malignant goiters. Signs: by inspection, there is dilated superficial veins in the upper part of chest and edema and cyanosis of the face. Palpation: in plunging goiter, the lower wall of the cervical goiter is not palpable. Percussion: there is dullness when manubrium is percussed. Investigation: chest X-ray shows widening of the mediastinum. CT scan reveals exact site and extension of the swelling. Thyroid scanning reveals the site and function of the thyroid gland as it shows. Treatment is by surgical is indicated in retrosternal goiter, especially for cases of obstructive symptoms and the cases with hyperthyroid. Toxic goiter. Common types: diffuse toxic goiter, nodular toxic goiter, toxic nodule. Other rare types include cytotoxicosis factitia, geopseudocytotoxicosis. Subacute thyroiditis due to liberation of hormones from the thyroid follicles. Hashimotoxicosis, 5% of the cases of Hashimoto disease. Function thyroid adenoma, function thyroid carcinoma, and anterior pituitary adenoma. Diffuse toxic goiter, either due to autoimmune theory with persistent or primary toxic goiter occurs due to abnormal thyroid stimulating antibodies. Long-acting thyroid stimulators could be detected in serum of 60 to 80% of thyrotoxic patients. Other members of RES, thymus, spleen, tonsil are enlarged. Abnormal, abnormal stress like psychic trauma, emotional stress, acute infection, pregnancy, and labor could precipitating factors for the disease. Abnormal stress is suggested to stimulate the hypothalamus and anterior pituitary to produce excess TSH, which acts on the gland participating in the disease. Pathologically, the gland is grossly enlarged, highly vascular, slight to moderate enlargement. This enlargement is slight to moderate. The cut section homogeneous, reddish brown in color. Macroscopically, lacini are increased in number and reduced in size with very little colloid, and there is lymphocytic infiltration. Toxic nodular goiter. Second toxic nodular goiter occurs on top of long-standing simple nodular goiter. The gland shows changes seen in simple nodular goiter with hyperactive internodular thyroid tissue. Solitary toxic nodule. It is hyperactive nodule that secretes excess thyroid hormones. It is an autonomous nodule that to say not under the effect of TSH. The gland shows hyperactive nodule. The overall thyroid functions are within normal in most of the cases, and as a result, hyperactivity of one of nodule and suppression of the surrounding tissue. Clinical picture. Most but not all of symptoms and sinusitis psychosis are related to excess thyroid hormone. Symptoms: thyroid gland, neck swelling, small to moderate, eye protrusion of the eyes, double vision and excessive tearing, CNS, musculoskeletal system, cardiovascular system, gastrointestinal and hypermetabolism, skin and hyperpigmentations, urogenital system, and complications. Signs: body build and attitude, extremities, pulse, systolic blood pressure are all changes. Signs in thyroid gland: there is a slight to moderate diffuse uniform enlargement of thyroid gland. The surface is smooth, skin over may be warm and with dilated veins. Consistency is soft. Eye signs: exophthalmos, tremors of eyelids, erythema. Diagnosis by clinical picture. This table shows a comparison between primary toxic goiter and second toxic goiter, and it represents a simple way to differentiate between both conditions clinically. Investigations include laboratory TSH, VT3, VT4, radiological as ultrasound, and radioactive iodine uptake scanning. Treatment consists of medical treatment, and surgical treatment in cases of failure of primary medical treatment or large disfiguring goiter or adult patients refusing medical treatment for a long time. Hypothyroidism etiology failure development of thyroid gland, dyshomogenesis, failure to secrete TSH, and Sheehan syndrome, iatrogenic or late stages of Hashimoto's disease. Clinical picture in children leads to cretinism, in adult leads to myxedema. Tumors of thyroid gland either benign tumors from follicular epithelium or from connective tissue. Malignant tumors are more common, primary as from follicular epithelium, 90% of the cases, differentiated papillary carcinoma, undifferentiated anaplastic carcinoma. From parafollicular epithelium, 6% of the cases are medullary carcinoma, and from the lymphoid cells, 4% of the cases are lymphoma. Secondaries, either by local infiltration or metastatic lesions. This table shows the main differences between the most common follicular cell carcinoma of the gland, either papillary carcinoma or follicular carcinoma or anaplastic carcinoma. Medullary carcinoma represents 60% of all thyroid malignant tumors. Special characters: high levels of calcitonin, diarrhea occurs in 30% of the cases. Clinical, Clinical picture of thyroid malignancy: symptoms, local symptoms, goiter, or recent onset of long-standing with rapid rate of growth, pain, felt in swallowing around the ear, felt in felt in the swelling or in the ears, referred by Arnold nerve to the auricular branch of the vagus nerve, symptoms of local infiltration, cough, dyspnea, suffocation, symptoms of lymphatic spread, and the symptoms of systemic spread. Investigations include thyroid function test, tumor markers, ultrasound CT scan, and MRI thyroid scanning. Treatment of thyroid carcinoma. Treatment of differentiated carcinoma, biliary or follicular carcinoma, total thyroidectomy, lymph node, either central lymph node excision if there is no palpable lymph node, if there are positive lymph node extension of the excision of the deep cervical lymph node. Isolated thyroid nodule. It is either as a dominant nodule of simple nodular goiter, toxic nodule of the gland, thyroid adenoma, thyroid carcinoma, Hashimoto's thyroiditis, de Quervain disease. This algorithm shows how to differentiate and clinically evaluate a patient with toxic nodule. Parathyroid gland development arise from the branchial arches 3 and 4. Inferior parathyroid associated with thymus and arises from third arch. Superior parathyroid arises from the fourth arch. 80% of the cases, there are 4 glands symmetrically distributed on both sides of the neck. In the remaining 20% cases, there may be more than 4 and unsymmetrical in distribution. This diagram shows the effect of hormone on both bone, kidneys, and gut. Hyperparathyroidism either primary due to autonomous production of hormone, secondary due to compensatory hypersecretion of hormone, or tertiary secretes as a secondary type of hyperplastic gland. Localization of the lesion by high-resolution ultrasound, which is accurate in 76% of the cases. CT of the neck, technetium labeled systemic scan, and find the patient with previous neck expiration. Selective venous sampling may help localization. Surgical treatment, adenoma excision of the diseased gland or glands, post-operative restore of the normal calcium level either oral or by injection.